All right, so this is Carlie Rodriguez will be speaking now. I am very fortunate to have her as my collaborating nurse practitioner. If she leaves, I don't know what I would do. So she's an oncology nurse practitioner at Ochsner, specializing in melanoma, head and neck cancer, and lung cancer. She had her bachelor's in nursing from LSU and master's in family nurse practitioner from Southeastern. Well published multiple areas of oncology. She's a true expert at immunotherapy toxicities, and I believe that's going to be the talk. Yep, or how to optimize urgent care in addressing immunotherapy toxicity. So, Carlie Rodriguez.
Thank you, everyone. Lower this. Can you all hear me pretty good? Okay. I know he says I'm the expert, but I don't know. I learned everything I know from him, so hopefully. All right. I don't have any disclosures and today's learning objectives. So we're going to talk about the type of immunotherapy related toxicities that we might encounter in our oncology urgent care settings. We're going to discuss how we might be able to promptly assess these and adverse events. We're going to describe the evidence-based management strategies for these common and severe immunotherapy toxicities. And then we're also going to talk about how interdisciplinary collaboration could help improve patient outcomes. All right. So immune checkpoint inhibitors have revolutionized the field of oncology and have expanded treatment options for various cancers. The great thing about our immune checkpoint inhibitors is that they have shown the potential for long-lasting responses that can lead to significant improvements in overall survival and progression-free survival for various cancers. So as you can see, we now have 4 categories. We have the CTLA-4, PD-1, PD-L1, and LAG-3 checkpoint inhibitors. They all work a little bit differently, but I have an example of a few of those. Some categories have a lot more that I can't include because it would be a very big slide. But the CTLA-4 checkpoints would block CTLA-4 enabled in order to enhance early T cell activation. For PD-1, prevents PD-1 from inhibiting those T cell responses. PD-L1 would block PD-L1 to restore T cell function. And then LAG-3 enhances T cell activation by blocking LAG-3's inhibitory signal. All right. In oncology urgent care settings, patients receiving immunotherapy may present with acute or even severe symptoms. The spectrum of immunotherapy-related toxicities can be diverse and challenging. These toxicities arise from the immune system's activation and can affect various organs and systems. Understanding the range of potential toxicities is crucial for prompt diagnosis and management. And here we have an overview of the spectrum of these toxicities that we could encounter in our oncology urgent care setting. So I felt this diagram kind of gave us a pretty good head to almost toe of what we could see a patient present to us with. All right. The mechanism of immune-related adverse events is driven by the unintended activation of the immune system, where the checkpoint inhibition enhances T cell responses not only against tumors, but against our normal tissues, leading to an autoimmune-like toxicities. So checkpoint inhibitor functions, these block CTLA-4, PD-1, PD-L1, thus removing immune breaks and enhancing that T cell activation. This then strengthens the immune system's ability to attack cancer cells. But then we have loss of tolerance. By increasing the immune activity, immune checkpoint inhibitors can reduce the tolerance to self-antigens, leading to that autoimmune-like reactions where the immune system is mistaken healthy tissues for what it's supposed to be targeting. And then we have T cell and cytokine-mediated inflammation. Activated T cells infiltrate organs and trigger inflammation. And then we have these excess cytokines that further amplify the immune-related toxicities, increasing that risk of organ damage. All right, so toxicity recognition. Early diagnosis and appropriate treatment of immune-related adverse events is critical for optimizing long-term outcomes and also for making sure the quality of life for our patients is not affected. So this is a timeline I put together of the immune checkpoint inhibitor adverse events. So while I gave you a timeline for potentials. Keep in mind that these toxicities can happen earlier than we think or even later, but we are able to see some consistency. So we have some early toxicities that may happen, and this could happen within the first few days up to 2 weeks. And these toxicities that appear in this time frame are usually infusion-related reactions, which could include fevers, chills, rash, and hypotension. But these are generally mild and only occur in less than 5% of patients. We then move on to our intermediate toxicities, which range from 2 to 12 weeks. In this time frame, we're going to see dermatologic toxicities pop up, things such as rash, pruritus, vitiligo, and these typically emerge around 2 to 6 weeks after initiation. GI and hepatic toxicities, things like colitis and hepatitis, are more common to happen between that 4 to 12 week time frame, especially with our CTLA-4 inhibitors. So these toxicities can be severe and definitely will require some steroid treatment and potentially discontinuation. Our late toxicities fall into the 6 to 24 weeks. This is when we start seeing endocrine-related toxicities such as hypophysitis, thyroiditis, and adrenal insufficiency. Typically, that's from the 6 to 16-week marks. Pneumonitis, myocarditis, and nephritis then develop between the 12 to 24 weeks. And then we have long-term or chronic toxicities that might occur, and this can go beyond 6 months. So some of these toxicities, particularly the endocrinopathies and arthritis, may persist indefinitely and even develop after our treatment ends. Sometimes we find these drugs are on target up to 70 days after a patient's last dose, but I've personally seen, and Danny has seen, even months, maybe even years later, but rare. All right, CTLA-4 versus the PD-1, PD-L1 inhibitor toxicities, just kind of a comparison of when we might see and what we might see. So CTLA-4 inhibitors like ipilimumab block early-stage T-cell inhibition, leading to a stronger immune activation and earlier and more severe toxicities. So these more severe toxicities can occur in 20 to 30% of patients, and typically these affect the GI tract, the liver, and endocrine system, with colitis being particularly severe. And then we have PD-1 and PD-L1 inhibitors like nivolumab and pembrolizumab that allow T cells to remain active in the peripheral tissues. Their toxicities are generally delayed and milder, but are more associated with pneumonitis and thyroiditis. Overall, 10 to 15% of patients can experience grade 3 or higher toxicities. So, in the grand scheme of things, that's pretty well tolerated amongst many patients. And then when we're using combination therapy, an example of that would be ipilimumab and nivolumab. The combination therapy significantly increases risk for toxicity, requiring close patient monitoring and early intervention. 55 to 60% of patients can experience grade 3 or higher immune-related adverse events, which is the highest among all the immune checkpoint inhibitor regimens. All right, so risk factors that we're going to look at. So a review of the literature identified certain demographics and social history that might predict an increased risk for immune checkpoint inhibitor adverse events. So patients that are under 60 years old, they have a high body mass index, women on CTLA-4 inhibitors, men on PD-1 or PD-L1 agents, chronic smokers, patients with sarcopenia or low muscle mass have all been seen to have a higher risk. So usually it's a combination of multiple of these risk factors that predispose a person to experience more adverse events rather than any single one of these alone. And then medical history. So a pre-existing autoimmune disease and even a family history of autoimmune disease seems to increase the risk for adverse events in patients treated with immune checkpoint inhibitors, especially inflammatory bowel disease. These patients are at higher risk for flares than, say, those maybe with an underlying rheumatoid disease. Allergies to foods, drugs, or even contrast may increase the risk of side effects in patients being treated for solid tumors. Patients with interstitial lung diseases, chronic obstructive pulmonary disease, asthma, or even a history of thoracic radiation can increase the risk for pneumonitis. Likewise, patients with cardiovascular risk factors such as hypertension, coronary artery disease, heart failure, and myocardial infarction are more prone to cardiac immune-related adverse events. And then kidney disease, of course, chronic kidney disease, stages 4 through 5, has a significant risk factor for an acute kidney injury. All right, medication history. So patients with chronic use of proton pump inhibitors and NSAIDs tend to have a worsening kidney function when treated with immune checkpoint inhibitors. The use of diuretics, ACE inhibitors, or ARBs can be associated with increased risk of acute kidney injury. Previous use of anthracyclines, HER2 inhibitors, and VEGF TKIs increase the risk of those cardiac adverse events. Antibiotics. There have been some studies that have shown antibiotic use, particularly broad spectrum antibiotics during or shortly before initiating treatment, can decrease the effectiveness of therapy and even increase the risk of side effects. And then vitamin D, that's known to have an anti-inflammatory properties, predominantly by dampening pro-inflammatory agent IL-17. So a vitamin D deficiency in cancer patients could also be associated with a higher risk for adverse events. All right, so there are some predictive biomarkers that we might be able to see to kind of predict the risk for these immune checkpoint inhibitor toxicities. Some of those being genetic biomarkers. So certain HLA genotypes have been associated with a higher risk of developing specific immune-related adverse events. For example, patients with an HLA DRB103 genotype have an increased likelihood of experiencing endocrine toxicity, such as thyroiditis or an adrenal insufficiency. Similarly, patients with an HLA DRB104 are more prone to rheumatologic toxicities such as inflammatory arthritis or polymyalgia. And then we have HLA-B35 genotypes, which are linked with a higher risk of pneumonitis and neurologic toxicities. Additionally, we have some germline mutations in CTLA4 and PTPN22. These genes are linked to autoimmune diseases that may contribute to a greater risk of side effects as well. And then we have some immune and inflammatory markers. So these markers can also help us predict risk. For instance, elevated levels of cytokines such as IL-6 and TNF-alpha indicate an increased risk for immune activation, which correlates with a higher likelihood of developing severe side effects. Additionally, T-cell activation markers such as PD-1 or even PD-L1 expression levels not only predict treatment responses, but may help us identify patients more at risk for toxicities. So a PD-L1 of 50% equal to or greater than 50% might have a higher risk of side effects. And then microbiome markers. Recent research has shown that the gut microbiome plays a crucial role in regulating immune responses to immune checkpoint inhibitors. Some bacteria appear to have a protective effect, while also others can contribute towards inflammation and toxicity. For example, the presence of, I'm going to try, fecal bacterium prosnitzi, I practiced that, so sorry if I butchered it, in the gut is associated with a lower risk of developing immune-related adverse events, suggesting that it has a protective role. And then on the other hand, an overabundance of Bacteroides species has been linked to an increase of colitis and other inflammatory toxicities. So understanding these microbial patterns could help us in new ways to help prevent or even mitigate the side effects. So predictive biomarkers may have an important clinical applications. HLA typing can help us identify these high-risk patients before starting therapy, allowing for closer monitoring and even early intervention. So monitoring cytokine levels and T-cell activation markers can serve as warning signs of a toxicity. And then another promising strategy is gut microbiome modulation. So the protective bacteria and then the overabundance of that Bacteroides species being linked, you can use strategies such as probiotics, dietary changes, and even fecal microbiota transplantation as a way to mitigate these toxicities. And then we have some emerging biomarkers and things to look for in the future. So new biomarkers such as serum proteomics and metabiolomics are being studied to detect autoantibodies and metabolic changes that are associated with toxicity risk. We have extracellular vesicles that may serve as early indicators of immune activation. Of course, the use of artificial intelligence is also playing a role. So they're using machine learning models to help integrate your genetic, immune, and microbiome data all together to develop a personalized toxicity risk score. So future research aims to validate these biomarkers and incorporate them into clinical guidelines. So far, no single test has yet been fully integrated into standard oncology guidelines for widespread use. As more data emerges from large scale clinical trials, we may start to see regulatory approval for these standardized biomarker based testing prediction tools. All right, so we're going to get into diagnosis and management in a minute, but before we start our patient, we're interested in knowing what your patient looks like coming to you and assessing for those risk factors. So, baseline assessments are essential for detecting changes while on treatment. This will help you detect potential or even subtle immune related adverse events. Taking an accurate history is important to identify some of the potential risk factors listed in the previous slides. There are many labs that could be indicated for patients planning to start these immune checkpoint inhibitors. Prior in our practice to starting each patient on checkpoint inhibitors and before each infusion, we typically check a CBC, CMP, TSH, and free T4. And if you're my nurses, they know this. Other labs you might want to consider, but are not essential for every time. If you have concerns endocrine wise, you may want to check an ACTH, cortisol, FSH, or LH. Some of our pharmacy protocols, honestly, where I work, want us checking an ACTH regularly, but I find that a little unhelpful. It does take days to turn around. It's not very useful unless we are checking a cortisol, which needs to be timed. So I usually check that as needed. If you have any renal concerns for your patients or they have a lot of or kidney disease that you're aware of, you could get a baseline urine dipstick just to fully evaluate what they look like. Any pulmonary pre-existing lung disease or chest radiation, you might want to consider getting a baseline pulmonary function test. Any cardiac issues or concerns, an EKG, troponin, or echocardiogram at baseline might be indicated. A history of diarrhea, if your patient comes to you with just unknown diarrhea that they haven't addressed ever, you may need to start that workup before you start your immune checkpoint inhibitors. That's happened to me before. So checking a fecal calprotectin, C. diff, stool culture, and even CMV might be indicated. And then also assessing for any latent infections might be helpful if we end up having to use a biologic in the future to help with challenging immune checkpoint inhibitor toxicities. All right, diagnosis and management. So we have guidelines put out by national organizations such as ASCO, the NCCN, and SITC. They have developed these guidelines to help us manage toxicities, and they use the most common scenarios such as initial presentation, initial management, and then they also go through management of refractory immune checkpoint inhibitor adverse events. So I'm going to get into some more specific toxicities that you're more commonly going to see in an urgent care setting. So pneumonitis, more likely to be seen when using checkpoint inhibitors that are a combination. This happens in approximately 10% of patients. It can be hard to diagnose, especially if it's in your lung cancer patient. Risk factors include chemotherapy, lung inflammation, previous radiation, previous existing lung disease, and a history of smoking. Common symptoms, of course, that we see are dyspnea and dry cough. The median onset for this is about 2.8 months, and a diagnosis is typically made with a chest x-ray or CT. Management would include, and I kind of have this just very simplified, not to get it overcomplicated, but for grade 2 pneumonitis, you do want to interrupt the immune checkpoint inhibitor. And at this point, you do want to start steroids, and that's usually 1 to 2 mg per kg per day of prednisone. For grade 3 through 4 management, you want to likely permanently discontinue. In this case, you would be using methylprednisone, 1 to 2 mg per kg per day. If no improvement is seen in 48 hours, we may need to consider adding other immunosuppressive medications like IVIG, infliximab, cyclophosphamide, or even mycophenolate. This is an example of a patient with pneumonitis, and Danny might recognize this. I think I stole it from you. So, as you can see, this picture shows, some pretty clear pneumonitis on that imaging, all that haziness. So, this patient was treated during a hospitalization, required IV steroids, and of course, needed a pulmonary consult. After all said and done, 6 weeks later, he has much clearer looking lungs. So, someone successfully treated using steroids, but unfortunately, he was hospitalized. All right, cutaneous toxicities. These affect between 30 to 50% of patients receiving immune checkpoint inhibitors. Grade 3 or higher are typically observed in about 2 to 3% in monotherapy patients and 4 to 10% in combination, so more likely to happen when you're using that combination therapy. Skin reactions caused by the anti-PD-1 or anti-PD-L1 tend to have a delayed onset in comparison to those when using the CTLA-4 agents. Typically, these cutaneous toxicities do not cause treatment interruptions. The most commonly seen rash is a macular-papular rash, and this is usually affecting less than 30% of the body. It usually takes on a follicular, pustular, vascular, or even an acneiform presentation. I put a picture up there of what we typically see when it's related to immunotherapy. That's a pretty classic rash related to immune checkpoint inhibitors. You do want to, be cautious in patients with a history of psoriasis. If they have active psoriasis that's already a problem, you definitely need dermatology's help and potential use of biologics if they're not already on them. Management. So if they're having a lot of pruritus symptoms, use of antipruritics such as camphor menthol, topical steroids, antihistamines, and occasionally other antipruritic drugs such as gabapentin or pregabalin might be helpful. If you have grade 3 rash, which is greater than 30% of your BSA that's being affected, you do want to consider holding the immune checkpoint inhibitor and giving systemic steroids. The nice thing is they typically respond pretty quickly to systemic steroids, so long tapers are not usually needed. All right, biologic agents can be used as an adjunct to help treat steroid refractory or recurrent cutaneous toxicities. They may be continued while attempting to also re-challenge with the immune checkpoint inhibitor. It's important that we get a skin biopsy if it's not our typical maculopapular rash. This will be important for histopathologic analysis and our choice of biologic. So there's various biologics we may choose based on what type of rash we're dealing with. All right, gastrointestinal toxicities. I feel very passionate about this, and I know the group I work with does too. But these can occur in the esophagus, stomach, small bowel, colon, pancreas, gallbladder, bile ducts, and the liver. Typically, we see this in the 6 to 8 week time frame after starting. Colitis is most frequently observed immune-related adverse event in patients receiving ipilimumab, and this occurs in 10 to 20% of patients. There are some life-threatening complications from this, such as ileus, toxic megacolon, and bowel perforation, which could all lead to death. So this is why it's important to really educate our patients on this potential side effect. So a grade 2 diarrhea would be considered 4 to 6 bowel movements above baseline. And at this point, this is definitely when I go and start collecting stool studies. I honestly tell my patients to call me at 3 bowel movements because they tend to not always remember the finer details, and I feel like 4 and 6 and we're already in trouble. So I changed that to 3. I'd rather know sooner than later. So after I collect these stool studies, typically we try to use our GI counterparts, but we have a team in place that we'll use if we need some assistance, but early endoscopy and tissue biopsies are really the gold standards for diagnosing immune-mediated colitis, so that's why it's important to have your GI counterparts understand the importance of this. Management for grade 3, you do want to hold treatment until you're able to get those symptoms to go back to grade 1 or less. Grade 3, we're still holding, and then we also want to consider permanently stopping that CTLA-4 agent. And then grade 4, of course, permanently stopping the immune checkpoint inhibitors. You want to make sure your patient's not using those anti-motility agents until we get those stool samples. And even then, using very cautiously. We don't want to mask any significant worsening of the diarrhea to where we're leading into those potential life-threatening complications. You may need to help support your patients with either IV fluids or suggesting a Bratz diet to help limit the diarrhea. Starting systemic steroids for grade 2 or above is definitely a must. Any refractory symptoms or failure to improve on steroids, that's when we talk about using our biologic therapy such as infliximab or vedolizumab. All right, so our biologics. So its selection of infliximab or vedolizumab is typically based on the patient and the underlying malignancy risk factors. Both drugs have comparable efficacy in achieving clinical remission in patients. However, there are some factors to consider when deciding which biologic to use. So vedolizumab is more gut selective. It's also not associated with the systemic immunosuppression. And then patients getting this drug have less corticosteroid exposure, fewer hospitalizations, and shorter hospital stays. Infliximab, though, does help us get a quicker clinical response, 10 versus 17 days. But there is the risk for infections, lymphoma, and other non-melanoma skin cancers that are reported with it. Often, the decision on which drug to use is determined primarily on how quick of a response we need. If a hospital admission is required for our patient, we often start infliximab in that setting. And then once we get them to outpatient, we try to get them on the vedolizumab and keep that maintenance going. All right, endocrinopathies. So hypophysitis, the incidence of this is about 10 to 15% with the CTLA-4 inhibitors. It is more rare with just using the PD-1 or PD-L1. Symptoms include fatigue, headache, nausea, hypotension, and electrolyte imbalances, more specifically hyponatremia. Diagnosis is usually with an MRI of the pituitary. You may see low ACTH, cortisol, TSH, free T4. Management would be hormone replacement. So we're talking about hydrocortisone or thyroxine, and of course, lifelong steroid therapy if needed. Thyroid, so we can see thyroiditis and hypothyroidism. The incidence of this is 5 to 10% with PD-1 inhibitors, more rare if just using CTLA-4. Symptoms are usually if we're seeing an initial hyperthyroidism, if it's significantly enough, palpitations or weight loss might be seen in your patient. Typically, this converts to a hypothyroidism. Could take several weeks. Maybe it never does. Maybe they go back to having normal TSH-T4. But if it does convert to a hypothyroidism, these patients might start complaining of fatigue or cold intolerance. Diagnosis, again, TSH, free T4, T3, or anti-TPO antibodies. And management, so you can use beta blockers if they're having symptoms from hypothyroidism. And then, of course, levothyroxine for the treatment of the hypothyroidism. Adrenal insufficiency. So the incidence is typically less than 5%, but it could be life-threatening if undiagnosed. Symptoms include weakness, weight loss, nausea, hypotension, and salt cravings. Sometimes I explain to my patients when I'm talking to them about this, you feel really bad. You feel like you're dying. You can't do anything. So I try to get past them. It may not be one or two symptoms. They're all pretty vague in the grand scheme of things. So I usually tell them, if you feel like death and you can't do anything, you need to talk to me. Don't just suffer through. Diagnosis is made usually with a low morning cortisol or an ACTH stimulation test. Management, of course, would be lifelong corticosteroid replacement with hydrocortisone or fludrocortisone. And then we have type 1 diabetes. The incidence of this is approximately 1% and seen with PD-1 inhibitors typically. Symptoms would be polyuria, polydipsia, and then a rapid onset of DKA. Diagnosis is typically made with an elevated glucose, low C-peptide, and positive JAD autoantibodies. These patients, unfortunately, will require lifelong insulin therapy and glucose monitoring. And then we have hepatitis. Most of these patients will present asymptomatic elevations in serum ALT and AST that are typically seen on routine monitoring. These typically happen 6 to 12 weeks after initiation. You do want to consider ruling out other causes such as their alcohol history, viral hepatitis, checking iron studies, assessing if maybe they've had a thromboembolic event, review medications that they're on. A liver ultrasound is helpful to help evaluate for liver metastases or another primary malignancy. Management will include, again, if you have grade 2 or above, steroids. If one of my patients was here right now, she'd want me to take a shot because every time I said steroids and educating her, she's like, we should make a game. Every time you say it, we should take a shot. But, probably not great advice if I want to keep working for the rest of the day. Refractory hepatitis, that's when we might bring in mycophenolate or tacrolimus. And then just keep in mind, infliximab is not recommended given the concern of the liver toxicity. Collaboration. So managing the immune-related adverse events presents a unique challenge that can be addressed at multiple levels with patients, medical providers, and institutions. So how does it improve patient outcomes? We can integrate expertise from various fields that would lead to a comprehensive and individual treatment plans for patients, help with developing innovative solutions. So creating specialized clinics and new protocols could help with better toxicity management. Enhancing communication, so among professionals, could lead to quicker identification and management of side effects. Patient-centered care. This would ensure personalized care that addresses complex interactions between treatment and patient health. And then educational benefits, the continuous learning and knowledge sharing among team members would enhance the ability to manage these complex cases. Patient education, this is the foremost thing that we need to do just because we count on them to tell us what's happening. So this is the first tool in managing our immunotherapy toxicities. They must know the potential toxicities and concerning symptoms. Ways we can communicate this is through printed materials like pamphlets, booklets, patient paperwork, even electronic media, on-demand videos that help address these toxicities. I know that's on my to-do list for this year is to make a video for our patients. So stay tuned on that one. This is an example of something we have done at our institution is to develop patient education specifically for immunotherapy. We have found that the education sources out there that are more mainstream really don't assess just immunotherapy. They kind of take on a chemotherapy language. So Danny, in starting his career at Ochsner, developed the majority of this, and I've provided some edits along the way. But this is helpful so that patients can be advocates for their own healthcare and help voice to providers when they're having potential symptoms. Nursing. So our nurses are our first line defense usually. So it's important that we are helping our nurses be educated in these side effects so that we can start the right treatment for any concerning symptoms. They're also helpful for helping us create guidelines and algorithms for managing these side effects. An example would be making the role of a nurse to be an educator for immunotherapy toxicities. They could help lead targeted clinician and staff sessions, help us conduct webinars, coordinate immunotherapy tumor boards, and serve as our primary contacts for information. So that could be what the future is. We don't currently have one, but it's not a bad idea to kind of help manage these toxicities. And then we have a toxicity committee to help manage these more effectively. Collaboration between specialists with an interest in these toxicities can be helpful, and that way we can bring expertise into managing them. Committees should include medical oncologists, APPs, nurses, and other relevant specialists. And then also identifying and designating these champions in each department that will help us enhance patient care and foster collaboration and research, and ultimately by integrating specialized management. And then e-consults. I know we're not the first place to do it, but an e-consult for immunotherapy toxicity is another useful tool for helping to provide expert advice and managing adverse effects associated with immune checkpoint inhibitors. This goal is to prevent patients from hospitalizations and also appropriate management. We're able to escalate these specialty managements sooner and hopefully prevent patients from suffering. And then lastly, there's some other practical applications that we can use to help manage these toxicities, such as guidelines and order sets pharmacies could maybe create to help initial immunotherapy toxicities. Developing guidelines that deal with toxicities that don't respond to corticosteroids, implementing tumor boards specific to immunotherapy, and this would help us share knowledge and communication. building support for research focused on immunotherapy toxicities, engaging the community oncology practices through outreach and telehealth, and then also collaborating with other medical specialties to help raise awareness of these immunotherapy toxicities. I have some references that I used to build this, and then thank you.